All right. Thank you, Hoon. Now that we set the stage, we are going to move to our first session. We have a set of amazing speakers lined up for our first session, bringing different perspectives for DP for health. Our first speaker is Lucila Ohno-Machado. She's a professor at Yale, and she's the Deputy Dean of Biomedical Informatics and Chair of the Biomedical Informatics and Data Science. She has been a great collaborator, and we've been collaborating for many years, and she is one of the really influential figures in the biomedical informatics and privacy-preserving computation. So she's going to give us a talk on health data sharing from the privacy-protecting technical and policy controls perspectives. Thank you.
Thank you. And I would first start to thank the organizers and the attendees today, and a lot of people who contributed to the slides that I'll show here very quickly. I'll talk about what it takes to access data from one single academic medical center and how to do that for a consortium of academic medical centers. And then now the problem with large models, whereas before we could share model parameters, now with these large models and memorization, it becomes a problem of yours as well, how to protect the privacy of shared models. So even the FDA, this is 2021, but came up with some guidance on what is called real-world evidence. So if you talk about clinical trials, they don't call this real-world evidence because it's a controlled environment, patients with eligibility criteria, control arms, and so on. When it comes, a drug or a device gets approved, it gets out in the real world, and that's when you know, is it working, is it not working, are there certain categories of presentations of disease that it doesn't work, or it causes certain adverse events that were not known before, and so on, or are drugs helping in other aspects? If you read about GLP-1s these days, they cure everything, right? They help everything. So again, analyzing some existing records helps with that. And it's not just electronic health records, but associated data. So genomic sequences are more and more part of the record these days, wearable data, imaging, and other modalities. So what it takes, for example, from an academic medical center such as the Yale system to protect those data. And I would say there is one thing that facilitates decision-making at Yale in which it is agreed that the data will never be sold. So that helps. That aspect of protecting intellectual property is not for monetization or anything, is not in play. But there are other things. There is reputation preservation, there is fear of lawsuits, there is respect for the patient, and a whole lot of other things that come into what we would call barriers to sharing that are nevertheless important. For example, we have about 4 million patients per year. There's 4 potential lawsuits per year. So you consider the value of trying to preserve privacy. This is just also, it's just not a one electronic health record system. This is a multitude of them, and they're all interconnected. Databases of other applications that are put into a common, and this is only the ecosystem for research. And there's also one for quality improvement and one for finances and so on. So there's a lot of people involved in various aspects of the data, and the data being transformed in order to serve certain purposes. So the EPIC system is optimized to quick response for the clinicians, whereas it's not optimized for research, so that they created a whole lot of other facilities around it. Here is, for example, also the difficulty in where to compute with those data, because there are laws that require HIPAA, and it's a particular Health Insurance Portability and Accountability Act, HIPAA secure environments. There is NIST 800-171 parameters that have to be used for dbGaP genotype data, for example. So if you're not ready for that, you cannot do the compute. And many times we have a mix of everything, and then you have to default to the most restrictive environment because there are parts of data in that. There are, in our case, on-premise, on the cloud facilities, they all have to be configured in particular ways to fulfill the standards. So it's not quite easy. You have intellectual property data. These are data use agreements with data that we may purchase or license for particular purposes. There is identified data, which is very common for studies, including there's sensitive data that is considered when you have a bulk of so-called de-identified data, but it's so much that the volume is so high that is considered more sensitive. There is also the NIH controlled access data repositories, the dbGaP I mentioned, ABCD study was also on New York Times News recently, and there are many others. There's the so-called de-identified data per HIPAA that can be used in less restrictive compute environments. But yeah, there is a whole lot of this to design, implement, and then monitor over time. And then there are the non-human subjects data, non-IP data, and that's the one that everyone computes with because it's the simplest you can give to students without too much training on privacy and other aspects. But it does take a whole lot to create these environments, to put the correct number of GPUs and everything there. IP data example, we do license Market Scan. That's one example. It's a claims database, so it's in kind of insurance data plus Medicare and so on. What those data don't have is results, but they have everything that was ordered when it was ordered by different institutions and so on. So they are valuable because you can track a patient across institutions, whereas other databases are more in one institution and you lose whatever happened in other institutions. So academic consortia have been put together because data from one academic medical center is typically not enough to create good models. In the COVID times, there was some relaxation of ways in which you could share data, and this was very helpful to answer some questions. If you remember in the beginning of the pandemic, people didn't quite know what was dangerous, what was not, and how to treat patients who did get into the hospital, right? Because in this case, we were talking only on electronic health records data. So we put together the VA system, which is this blue crosses across the country, plus some academic medical centers, and one international one in Munich, just to figure out, do we have enough cases that we know that mortality has increased if you do a certain procedure or not, and so on. So there were not that many cases in 2020, but by having this consortium of institutions, you could answer some very simple questions. One of them was for patients who are hypertensive, can they continue to take ACE inhibitors, which is possibly the most common medication that they do? Because there was some concern about the receptors interfering with the COVID action and so on. So by aggregating data, in this case a very simple question, univariate question, we could show no, that you should continue to give ACE inhibitors because if anything, they seem to be better than the other medications in terms of mortality for people hospitalized with COVID at the time. So it's useful not only for research, but also for clinical practice to share data, but it has all these impediments that I mentioned before. After that, a couple, 3-4 years ago, EPIC, which is a major electronic health record system, came up with a consortium named Cosmos. Then institutions that buy this particular record system, could put together their data, and only they could consult that pool of data that Epic would maintain. And again, ours is one of those, but there are 293 million patients that you can query many more things in that way. And many more hospitals all across the country and so on. So it is yet another example of a useful consortia. There are also research consortia specifically to share, and that's simpler because the patients do consent for those data to be shared, whereas in the other examples, they do not, which is why it has to be the so-called de-identified data to be used and never, or limited data sets, which is another thing. For those research studies, you can use federated algorithms, so Ohno is working on that, for example, but it's a different thing. It's not real-world evidence in the way that we mentioned before. And there's also generative AI now with large language models being used, and also DNA or other types of large models. How healthcare organizations are using AI, that's one, one rare counterexample of that delay adoption, because it was so fast, the adoption of the virtual scribe, which is ambient AI. It listens to the visit and creates the summary that the doctor approves, or to be used as a first response or a draft response for emails that the patients direct to the doctor. So this is in use right now. It did not save time, as people said it would. It increased somewhat satisfaction, and it's cheaper than human scribes. Again, how much outcomes have gotten better, we don't know yet. That will take longer. There is also, for clinical research, training existing foundation models with medical data or even brand new ones. But this is mostly done with published medical cases in biomedical literature, because if you do use real observations, there is a lot of restrictions in these models. So a team of Yale, Florida, and Texas got together to do medical llama, so you can tell which foundation model it was based on. And it was continued pre-training more with biomedical data. And as you can see in the illustration here, the only clinical notes used were from Mimic. And Mimic, some of you know, is a kind of shared database, but also with a data use agreement, meaning that data use agreement passed to the model as well. So any user of Mimic needs to sign a user agreement. Collections shown here. These models were shown to be quite adequate, but better, definitely better Llama itself, and they're getting better over time. So every time you do some evaluation, some other model came, and then you're already old. EPIC, in this case, there are two faculty members of my department who have worked with the EPIC team to build the Cosmos-based foundational model. So from that pool of data for research that they had, that they created a foundation model. And it's an LLM, but then again, the next word prediction is based on coded sequences of medical events. So what you're predicting is what will happen to that patient next, right? So you can simulate what will happen next. You can say, well, if instead of this medication, you use this one, what is the prediction, the trajectory that is expected? And so far, so good. It has been, is promising. It's available, so we're already doing some work with it. And in this very preliminary, the first time they went around it, the advantage here is you're not training a specific machine learning model for each one outcome that you're thinking of, right? So that you're using this foundation model to evaluate a lot of different clinical prediction tasks. So they list some here, and that they were better, the majority of them, they were slightly worse in a few of them. And this is all the zero-shot performance of this medical language model. So quite interesting, still a lot to be done, but also a lot to be done outside of EPIC, right? With data from these academic medical centers collaborating. And this, again, I would say the limitation is just funding, is not necessarily other IP and these other things, because when the academic medical centers are among themselves, there is a higher level of trust than otherwise. So the challenges are the privacy, the black box nature of AI. Computational infrastructure is very demanding, as we know, but there's opportunities here. We also got together with a team in Toronto, in London, and Indiana to look into DNA language models. And this particular one called EVO2, developed at Stanford, was just trained with DNA sequences of every living species, with just one human, the reference human genome being included. And why were we interested in it? Because you could, just with the evolution aspects of the sequences, determine that, for example, BRCA1 was a very influential mutation, right? So we were interested in, so is it for Alzheimer's, is that same true? Without any training specific and with that one human reference genome one, would it pick up the ApoE gene, which we all know is very related? And it did do very well. So in here, I'm just showing how strong in GWAS an ApoE signal is. And this, if you look at the dotted vertical line here, is where the ApoE signal is in GWAS, and which is with the absolute Z-score, and in the EVO score. So again, a model not trained, absolutely no Alzheimer's disease or anything, just on the sequence of DNA, could determine that that's an important locus, an important mutation in there. We did that for available data sets as well, and see that amyloid plaque and for mild cognitive impairment as well are correlated with the EVO score. So there is something in there worth exploring. What is the issue is that once we start putting real-world data in there, then who can use those models moving forward, right? What are we approved to use or not? So it's very interesting that I'm here in this conference, because if you guys can figure that out, I think it will be very influential for medicine in general, because then we can have more people use these models, right? And you know, we know data and models are kind of the same thing right now, so it needs to be thought of some solution to that. So generative AI has great potential, but the privacy risks are there, perhaps more than before. Models and data can breach privacy, so there is a tremendous role for what you do. And I'd say it's still the case that natural intelligence is needed to make the best use of artificial ones. And it might not be in the future, but for now, we're like that. So thank you so much.